Thank you all for being here on this Friday morning. My name is Laura Burke, Austin Kilroom, Amber Sabatini, and we're here to discuss new directions for emergency medicine research using administrative data. The disclosures are here.
Use the mic, Laura.
Oh, okay. Better? All right. So I'm a health services researcher in addition to an emergency physician, and I know that there are some other health services researchers here. So I probably don't need to emphasize the importance, but why health services research is always the question. And that's because a lot of people have opinions about the work that we do, and a lot of the time these opinions are by people outside of emergency medicine who make policies that really impact our field. And not infrequently, those opinions aren't necessarily informed by evidence or the realities of what we do on the ground. And health services research is really important to push back on any misconceptions and to make sure that the policies that affect our specialty are driven by evidence. And thankfully, we have health services researchers in our field who've been able to do some high quality work to inform the policies that impact our work. Multiple studies that have shown the types of practices that exist in our specialty can impact vulnerable populations. Insurer-payer policies can impact our specialty, and really providing that evidence to suggest that we need to do better. Well, what types of data sets are available to do this work? There are many, but broad buckets include claims data, electronic health records, registry data, publicly available data sets, and there are a number of others that you can use that exist by state. So how do you choose? Well, there are advantages and disadvantages to each of these. Claims data is very common, and one of the advantages is just you have a pretty large sample that you can readily perform multiple analyses that are often generalizable to the broader population. Electronic health record data tends to be more limited in terms of the number of people included, but has greater clinical detail. Registry data in many ways can combine the benefits of the two. It tends to include a larger number of individuals, and it also has more clinical data that's not present in claims. And then there are other publicly available data sets. The Medical Expenditure Panel Survey and HAMCs, NEDS, and state data sets such as PDMP programs all exist to help us as existing tools to do this work. So I'm going to talk primarily about claims. That's mostly what I do. I work primarily with Medicare, but there are also Medicaid claims. Amber's work with that, all payer claims databases, and commercial data sets. So what are the advantages of claims? Improved generalizability, large sample size to really look at more rare outcomes. Once you kind of have the data set assembled and know what you're doing a bit, you can efficiently perform multiple investigations. A lot of the time when you're using clinical data from the EHR, you may not be able to see what happens after the patient leaves the ED, or at least know that you're conclusively capturing all healthcare encounters. With claims data, you often know that you're seeing all clinical encounters, regardless of where they occur, to get the broader picture of patient outcomes associated with emergency care. And you can also look at costs. So depending on the claims data set you have, you can look at a broad range of service lines to really look at the total costs and efficiency of care. What are the disadvantages? So I mentioned limited clinical data. So you don't have, most of the time with claims, you don't have lab values, you don't have vital signs. You may have limited indicators of patient-level socioeconomic status. That's something we debate a lot for risk adjustment. You might have area-level indicators, but of course, people vary within those areas. So it is a key limitation of many claims data sets. And depending on the particular claims data set, so Medicare is unique in that you have death date. It's linked to death index, but not all commercial claims have that. So you may not be able to confidently know that you're identifying mortality should it occur. Medicare claims is my favorite. That's what I do mostly. And you have a large national sample. Most of the studies use people 65 and over. The under 65 population is unique, and that you have to qualify for other reasons such as disability or end-stage renal disease. And it's certainly a population of interest, but may not always be generalizable. Obviously, older adults are high utilizers, an important population of interest to study. You really can look at so much. So as I mentioned, it's linked to death records, so you can conclusively identify if patients have died after an ED visit. You can look at inpatient, outpatient, post-acute care claims. So there are really multiple questions you can answer with this data set. And one distinct advantage compared to some others is that for each hospital, you have a provider ID. So you can just Google the provider ID and know which hospital is involved. But you can also link that to other data sets, such as the Dartmouth Atlas, which has indicators of healthcare supplies, such as hospital beds and physician supply. And it's nice that there's a growing community of researchers, certainly within EM and beyond, that can help you, since it is a bit of a complicated data set to learn at first, but once you get the hang of it, there's so much you can do with it. And there's also the ResDac, which is CMS has this resource. They have an online data dictionary, but also you can reach out to them for support and to ask questions, and they're actually quite good at getting back to you. So examples, Ziad Obermeyer did the landmark study, death after discharge, after an ED visit, and this is just a classic example of how you can be sure that you can study these outcomes that you wouldn't be able to look at with ED, like your single center ED data alone. We had looked not just after discharge, but across a range of dispositions, but also costs. So there's people have a lot of opinions about the cost of emergency care, and certainly it's important to be efficient. But we know that there's been a growing focus on value and looking at not just an individual service line, but an entire episode. And so we know that if we just look at the ED visit or the inpatient stay, rather than what comes after, if we spend more in the ED and we're actually able to save an admission, we can lower total costs. Medicare data is one of those data sets because you can see all the service lines that a patient has in an episode. You can really provide a broader picture of the value of care. Medicaid claims. So I actually started working with Medicaid, state-level Medicaid data before Medicare, and the data set is fairly easy to use, but the policy is complicated. So by virtue of that, that's what can make it difficult to work with Medicaid, is you have to understand that New Hampshire Medicaid is different than Massachusetts Medicaid by virtue of the policy design. So it really requires understanding the policy, but once you get that, working with the data is fairly easy, and it has a lot of the same advantages of Medicare, including death dates and having a wide range of outcomes. Commercial claims. So if you're lucky to get access, sometimes these can be purchased, but oftentimes people have existing relationships with other researchers. Private insurance companies may have working out the data use agreement so you can study what you want with an entity that has a financial stake in making sure, limiting the number of questions you can answer. But if you can ask a question of interest and get access to this data and understand what's going on in the commercially insured population, it can be very powerful. But not all questions are appropriate for these types of data sets, like Medicare or Medicaid or the commercially insured. You might want to know about all payers or the uninsured. So an elegant study by Arjun Venkatesh looked at the impact of insurance status on patient transfer. Michelle Lin looked at trends in disposition for all payers. So NEDS is one way where you can really look at all payers, the National Emergency Department sample that a lot of health services researchers have used within emergency medicine to get around the limitations of these other data sets. And HAMCs, so this actually has lots of advantages, but it's another way you can look at what happens with patients who have no insurance or have other types of insurance that aren't included in other claims data sets. State databases as well. Obviously, everybody's familiar with Renee Shaw's work and the important work she's done on looking at disparities in access to care. The California state databases are really a powerful tool. I mean, it's one of the largest economies in the world to inform emergency care delivery and has all payers in that data set. But what if you need greater clinical detail than any of these can provide? None of these have, actually NAMCS has lab values, but registry data. So Corey Zackerson at MGH is a stroke researcher who is stroke is one particular condition that's hard to use claims because NIH stroke scale is such a big driver of the severity of the disease, and claims just don't have that. But registry data actually has that advantage that it has clinical variables of interest for a particular disease process for a large number of patients that can really provide a middle ground in terms of sample size and clinical detail. One of my favorite studies of all times. So claims data do not have chief complaint, and that's important because patients don't show up to us with diagnoses, they show up to us with chief complaints. And sometimes working back from the final diagnosis isn't really the right approach. One of the few data sets that actually have chief complaint is the NHAMCs. This is another great survey using NHAMCs, looking at trends in the intensity of emergency care by Andrew Cho. Again, taking advantage of this data set, which has good clinical detail for both inpatient and outpatient visits. So for claims data, for the most part, if the patient's admitted, you lose a lot of clinical detail because the claims actually don't have that for patients who are admitted. They just get one lump payment, and it's not for the individual CT scan or lab value, and HAMCs can get around that. EHR data is also important for clinical detail, so with that, I will turn it over to Austin.
Hey everyone. So, as Laura mentioned, we're going to be talking about opportunities for EHR research. So, what do I mean by administrative electronic health record data? It's not the data that you would use your armies of medical students to extract, as powerful as those armies may be. Really what we're talking about are data extracted from the EHR using database queries. And this data provides a wealth of very detailed clinical information, most often used for retrospective studies, but actually could also be used for prospective studies. So as all of us know, the major EHRs, Epic, Cerner, these were primarily constructed for billing purposes, and then maybe secondarily clinical applications and point-of-care use. They weren't really constructed for research. Some EHRs offer some frontline users the ability to extract data for QI purposes. Epic has a tool called the Slicer Dicer tool. But again, that isn't really a tool that you can use for patient-level research, and it only provides a small kind of a shadow of the clinical detail that's available. So instead, EHRs communicate with separate databases that you can access separately, typically using a programming language called SQL, which allows you to access databases and allows you to pull very, very detailed information. The catch, obviously, you get a diamond mine of information, but the catch is that you need the infrastructure in your health system and you need the personnel to extract that data, and everyone, all health systems are looking for the folks that can actually do this work. So what are the strengths of EHR data? Well, I've said this a couple times already, but it's incredibly detailed. So, it can rival registry data in some ways, that you get everything that's ever been recorded in the EHR, and very importantly, you get timestamps for kind of all fields that are entered. I think, especially for emergency medicine, access is a huge strength for EHR data. So we all have it. And again, this depends on your department, depends on your institution and the resources and personnel that you have, but it's something that you can get. And finally, you can get it quickly. So there isn't really, if you have the right infrastructure, there's not a huge lag to obtaining this data. It can be updated in real time. And you can actually start with a project, pull data from the EHR, and then refresh your query as time moves on to increase your study period or expand your power. So obviously it's great, but there are some real weaknesses. And there's many more weaknesses. I'm just going to mention 3 that I think are worth thinking about and need more discussion in the community of researchers. So first of all, EHR data is often a single institution or single health system. Your health systems are consolidating, so you may get access to multiple hospitals within a health system, but still you're limiting your generalizability. It also, that problem also creates some issues for power, depending on the kind of study that you're doing. And then we'll talk about this more in a second, but validity. So not just generalizability that you put down in your limitations section, but is the data that you're extracting actually valid for the exposures and the outcomes that you're trying to capture for your study? Second major challenge I want to talk about is missing data. So the issue is that everything is recorded in the EHR, but not everything is recorded for everyone, right? There are obviously some statistical ways that you can handle missing data, but it's not just the statistics around imputing missing data, but it's also how missing data creates bias, and data may not be missing at random within the EHR. I think it's important to note that, again, that the EHR wasn't constructed for us to do research, so we have to figure out ways to address that bias. And then finally, consent. So often we're able to extract data from the EHR in a de-identified, confidential way, but I think it's worth discussing, what do we do about more sensitive information? What if we want to link this data with other data sets that does require identification? And what about prospective studies that we can use with EHR data? So I want to go into this in a little bit of detail, starting with single institution. So apologize for using my own paper, or our own paper. Kit Delgado, the leader of this, was also involved. He's here. Yeah, I thought this was a helpful example. So early in COVID, we were noticing, I think as probably many of us were, that we were getting bounce backs. So we were discharging patients that seemed relatively stable at discharge, good oxygenation, and they were coming back in 7 days, and we were admitting them to the ICU or intubating them or worse. So we wanted to just do a quick study looking at what was the rate of patients returning to the ED, and are there any salient patient characteristics that might predict those returns, especially at the time there's a lot of papers coming out around patient characteristics that predicted worse outcomes from COVID. So we were able to pull data very quickly with the help of an analyst from the Epic Clarity database at our health system, and clinical characteristics of those visits, getting fairly detailed information, including ED vital signs, length of stay. But the major challenge was actually our outcome, right? So we were able to identify all of the ED visits of patients that were discharged from our ED with a diagnosis of COVID that tested positive. But the challenge was, how do we find out who was returning to the hospital or EDs outside of our health system? We couldn't call patients to figure this out, and we have access to Care Everywhere for individual patients, but you can't use that. It's an Epic platform. You can't use that for research. So we were very lucky to create a partnership with our regional health information exchange called Health Share Exchange for southeastern Pennsylvania and Delaware. So health information exchanges are partnerships between health systems that are established at the regional and sometimes the state level that allow for health systems and physician practices, nursing homes, to share clinical information, and it's typically, again, for the purposes of clinical practice and quality improvement. But increasingly, HIEs, or health information exchanges, are offering their data to researchers with certain caveats. So our partner was very eager to help us, but we could only receive just a limited amount of data. They weren't able to, within their agreement with our health system, or all of the health systems, to provide any identifiable information. But if we were able to give them a list of patients, they were able to tell us whether they had been admitted at different hospitals, how long they were admitted there, and actually we were able to get mortality and length of stay information. So this dramatically changed our study. So we found that out of about 1,500 patients, that 5% or so returned to an ED within 72 hours of discharge. A good chunk of those returns were at hospitals that were unaffiliated with our health system we would have missed if we had done the study without accessing this database. So going on to this missing data challenge. So again, it's not really so much a statistical question as a structural question, I think, with missing data. And I'll use the example of social determinants of health. So we all know that social factors are the main influences on health outcomes, yet they're inconsistently captured in the EHR. I don't know about you, but I'm not in the habit of updating my social history. When I'm doing my charts, I kind of just let whatever is there enter the chart in my template. But you can imagine if you're doing a study on outcomes from COPD and you don't have smoking status, that's a difficult study. And then there's even more powerful influences on health that are even more intangible and may not live in the EHR in a structured way, something like social isolation and support. So I will argue that this is actually an equity issue as well, so that data may be missing for certain populations that have better PCP access or more engagement with the health care system may have some of these fields available to them. And the fact that data may not be missing at random actually can perpetuate bias and challenge validity for your study. The good news is that there are new techniques to extract some of this unstructured information from the EHR. Actually, there's been multiple abstracts at SAEM, which is great, looking at natural language processing and machine learning techniques to be able to take the unstructured chart elements, so from your ED notes or outpatient notes or inpatient notes, and identify the key exposures and outcomes that we need to do better retrospective research. This is just a systematic review that I thought was very interesting, and I think one of the takeaways from this is that there's intense interest in using NLP and machine learning to extract social determinants of health information. There's a wide variation in how you do it. So there's some very simple approaches that are more kind of keyword-based to the best approaches, which use machine learning, train on a data set, and then figure out ways of kind of pulling things in an empirical way. I think hopefully, fortunately, as we go forward, that some of these machine learning algorithms will be available to the community of researchers on like an open source platform that we can just access. One final note about this is that there's data in the EHR that you didn't even know was missing. And this is a great study from UCSF that looked at basically trying to see if NLP and use of unstructured elements in the patient chart could improve on ICU mortality prediction compared to the Apache scoring system, which is commonly used for ICU mortality. And they found that they were actually able to increase the predictive accuracy of the Apache model by pulling terms from EHR. I don't think anybody would be surprised that if pupils are fixed or ECMO or PEA was in the chart, that would predict ICU mortality. So not a huge shocker, but still the concept is cool, right? That the fact that you're like getting data that you wouldn't even know to necessarily look for those terms in the chart, and actually improves your accuracy. Last challenge I'm going to talk about is consent. So I'm really not an expert in consent or ethics, but I think this is important for us to discuss kind of as a community. So this is another study I was very fortunate to be a part of. The PI is Dr. Kit Delgado. This was just published in New England Journal of Medicine as a research letter. So we wanted to test home pulse oximetry combined with a automated text messaging check-in platform called COVID Watch among patients that were outpatients and also patients that were discharged from the emergency department against this text message-based program alone. So this is a pragmatic RCT testing home pulse oximetry plus a home monitoring program against the home monitoring program. I think what's notable about the study is that we collected data purely from the EHR. So we did not need to survey patients or actually consent patients. We actually obtained a waiver of informed consent. So patients were randomized to either the intervention versus the control without us necessarily approaching them. And this allowed us to do a rather large pragmatic RCT in a very short amount of time under kind of difficult circumstances in the middle of last year. So I mentioned the study in that this is an example of data that's collected prospectively in the EHR that's allowing us to do research. So it's not necessarily your typical kind of use of administrative data. I think the issue of consent, though, does influence the design of the study. So as I mentioned, our study, basically, because we received a waiver from informed consent, we had to provide patients with at least the basic standard of care. So all patients in the study received an automated text message intervention. Patients were randomized into receiving the pulse oximeter on top of that. And in our design of the study, we could not have three arms, right, of a group of patients receiving no interventions. And so that influences kind of the results that we ended up getting. So with that, just to summarize, EHRs are great. They offer very detailed clinical data, and it's worth having the conversations early with your health system to build the infrastructure and the resources they need to be able to pull it. We should anticipate the limitations to using EHR early in the study design and recognize that there are new techniques that are advancing very quickly that will only allow us to do better research with this data. And then I think consent remains a gray area, and it depends on your local institution and your IRB, but also I think merits discussion about how we're going to address kind of consent for patients in using this type of data going forward. Great.
All right, so I get to talk about the most fun stuff, I think, but just a really quick piggyback on what, I speak really loud. Is this okay without the microphone? So just to piggyback on what Austin was saying too, one of the massive trends that's happening right now in just healthcare, right, is data. It's underpinning how we pay for healthcare, how we do value-based care, health systems, payers, they're all tracking health metrics. And because of that investment, stemming from payment changes, we are essentially having this data revolution, right? And so it's up to us to figure out how to use data in novel ways. So there's a lot of health systems now that are curating and consolidating data from many hospitals. Like in my area, the Providence Health System is sitting on a huge repository of data, Kaiser, Jesse Pine's group, US Acute Care Solutions. So there's also ways to use this electronic health record data to be more generalizable. And those resources are often available if you just kind of like contact their data people who are managing these electronic data warehouses. tell you you can get that for free from CMS hospital reports, cost reports. And all of that was linked through hospital ID. It would cost you a lot of money unless you were reusing this data from other people. But once this data is already at your institution, very quick study to do actually. I guess I didn't put it. And they find essentially that higher quality stroke hospitals are more likely to receive transfers. All right. And then this is the last study I was going to show you. I wanted to show you a study that leveraged one of those national surveys. So there's been about 200 papers on Medicaid expansion and its impacts, but I liked this one because it was really cheap and easy to do. So they were interested on how Medicaid expansion impacted low-income parents and their access to care. And so they used a national health interview survey and they got all this cool stuff. They found out how many dependents patients had, or the respondents had, so they could identify parents. They had information about income, insurance coverage, whether or not they had a usual source of care, ED, and office visit use in the past 12 months. It's self-reported data, but whether or not the patient had a difficulty finding a provider in the last year, and also this survey tells you if patients had an unmet care need in the past year. Then they linked it with expansion status of the state, which is not that hard. And then they went to Kaiser Family Foundation to identify state differences in eligibility expansion thresholds for parents. All very easy data to get and not very complex. So cheap and easy to do, and they got published in Health Affairs, which is a good policy journal. And without really getting into this, they saw that it had some improvement on cost pressure for patients and access to care. And this is the last thing I'll show you. So this is a data schematic that I adapted and poached from Renee Shaw, actually. So I included this in my last grant, and it shows you all the data sources that we chose to link. So we were working off Medicaid claims to look at the impact of health information exchange. And we said, we'll link it to area resource files, proprietarily collected data from the vendor, hospital compare data, and physician compare data to look at quality, and then the Medicare cost reports for looking at hospital level factors that may modulate the effect of this health information exchange. We ended up not using a lot of those in the end, but that was what we proposed anyway. So you can do some really fun, innovative stuff if you can think more broadly about how all these factors are intersecting in these like complex systems, right? And we now have data systems that allow you to do this cool stuff. All right, and I just want to end with like a really quick note on how you can jump into this. So of course you can use all that free public data, but some other ways to get data that maybe has an input cost. So HCUP has discounted rates for students and trainees. All you need is a letter from a faculty advisor. So if you are faculty, you can find a resident or a student or someone who wants to work with the data. You can write them a letter and you can get it for cheaper. It's probably the case that someone at your institution has that as well, and you can just sign their DOA and work with them. So like find collaborators and reuse data. That's the short story. Claims data is really expensive, but if it's at your institution, you can reuse it for $2,000. There's probably additional data storage costs depending on your infrastructure, but in other words, it's pretty cheap to do a study if it's at your institution. So find a collaborator and ask them if you can reuse data. Nobody, like when I get a grant that says you get Medicare claims, it doesn't go to me, it goes to my institution, okay? So it's technically not my data, it's University of Washington's data. So you can reuse it too if you get consent. Same thing. Okay, someone did a really cool survey and you find a new application for it, contact the author and say, can I reuse your data? And see if you can think about these ways and then link it in with these publicly available data sources, you'll lower your cost, you'll lower your time, and you'll be able to do really cool things. Interestingly, I reached out to Commonwealth Fund recently because they've done a national survey of federally qualified health centers, and I was wondering about the future of that. And they said, we don't know if we're going to do this survey again, but if we do, we'll contact talk to you again about inserting some new questions in it. So these kind of things exist, and these organizations are willing to share data and partner with you in a collaborative fashion. Cool. That's all I got. Do we have time?
Yeah. We have just a few minutes for any questions. Would appreciate also if you guys could fill out the survey as well. For the research committee.
Thank you for very stimulating discussion. Listen, I'd like to ask you sort of a general question. It seems like what you're doing requires that you be familiar with a variety of databases, A, and B, that you have a statistician who's comfortable with this cross-linking process. And so I wonder if you could think out, those of us who don't have this high sophistication of resources, what steps there are to be able to be, get your statistician working on this level, and just whatever thoughts you have on that whole maturation process.
Well, it kind of depends what data sources you're linking together and how complex that is. Some of this can be done in Excel, and then very simple like regression analyses. I mean, you would need some basic skill or have someone that has a very basic skill. Obviously, working with claims data sets takes a level of analytic skill and complexity. But on these national data sets, you literally go online, you download them to Excel, and then you can put them together that way. I would say those projects are often what like a research fellow would like get their feet wet doing. So they're not complex, actually. Any other thoughts?
I think too the advantage of working with one data set is building up some familiarity. Certainly, like when I started working with Medicare data, I started doing some of my own coding. So I think that helped me really become familiar with the data set, but it is complex. And I think that's the benefit of working with others in this space. If you can get involved with others who know the data set and can inform you on some of the benefits and limitations, and then you can gradually build towards more independence with that particular data set. And a lot of the knowledge, it translates into other data sets as well.
Yeah, I think being free with collaboration and just, reaching out saying you want to share, you want to work together, and it's kind of the way to be productive in this space.
I would just add, again, like cross-site collaboration too. It's a fairly small community of researchers that are interested in kind of HSR and this type of work. And so I think that honestly, we have a lot of opportunities for kind of more national like cross-site if you don't have the people working with a particular data set at your institution.
Thank you guys for really doing an amazing job. I think simplifying and distilling what I think is often such an intimidating and overwhelming topic for a lot of people. And I'm wondering what you think about, how you think about, some of this is obviously the term and the framing of health services research even can I think be a barrier in and of itself in terms of people understanding the richness and the amazing questions that you can ask related to policy and disparities and equity and access and all of those things. And I'm just wondering if you have any thoughts about how we can, should we be calling it something different? Should we be, what we can do to be able to, other than what you're doing now, which is amazing, to be able to sort of share what kind of amazing questions and answers you can get at with this type of work.
A branding issue.
Yeah.
We don't brand ourselves well. That's right. It's because it's a broad area. But I don't know, health outcomes research and patient-centered outcomes research. Sure.
And the more emergency physicians that do it and involve trainees, we can demystify the process. I mean, we certainly have a growing number in our field, but a lot of us go to Academy Health where you see the broader pool of health services researchers. We really need more emergency physicians in this space to answer the key questions. It's surprising how many EM-related health services studies you'll see conducted by non-emergency physicians, and it shows because they don't understand necessarily what the realities are for us. So involving trainees, having more of us present this work, and just demystifying the process. I mean, it's no harder than a lot of the other research that's done at this conference. So just making sure that it's publicized and that we're collaborating and involving others, I think will go a long way to building up health services research within our specialty.
Hey, wanted to ask your thoughts for both of you on
I think it's a great question. I don't know the ins and outs of the politics of offers of information technology, but I'd say probably we're far away from having a truly national EHR. I will say that at the state level, I think we have, maybe that's our first great opportunity. I think Amber mentioned some studies from California that use OSHPA data, which is exactly EHR data, but I was doing some work in Maryland recently, and they have a phenomenal information exchange statewide called CRISP. And they have it because they have a very unique billing and payment policy. But I think going forward, it's going to continue to kind of look further really good research. So it may, I think starting at the regional, state level, and building some information for the national.
Massachusetts created the Chapter 55 was a law around the opioid epidemic, and really actually had a great linkage of novel data sets, including death records, EMS records, correctional records, to study a public health emergency. So, I think it shows it could be done. I do think we're a little bit far off. It would be so nice if we could have data like Denmark has to really study a lot of these issues, but hopefully we can get there with advocacy.
I don't think we're ever going to get a universal EHR in this country, but we're getting some really big linked electronic data warehouses, either at the state level. I mentioned Jesse Pine's group because they're interested in collaborating, by the way. You get each of these are biased samples, right? That's community emergency, but it's like 300 or 400 really across the country. Kaiser, right, going to one of they've got big networks. The VA to some degree, and the other one would be, like, I know Providence, I just did a study with like 60 hospitals. So you can get, more robust data than just thinking about your single site through these networks that are being built, but you have to reach out and usually collaborate with one of their folks.
Just to comment on that, we've done a few papers that way, where you get really big numbers through systems, hospital systems or administrative data, and you touched on that already, and even though it's not nationwide, you can get quite a big sum. I wanted to ask you about, just real quick, about expanding on using a student. We thought about doing that because the price is so much lower at accessing these databases. Yeah. So how do you do that? The institution pays for it, and it belongs to the student, so you have to make sure the student's there for a while, or if you could just delve on that for a moment.
Well, if you're going to do that, your trainees should be very involved in the research. Like, you shouldn't put them by name only and use the research for yourself, but you should be mentoring them through a project. But usually that money comes out of your own budget, right? But it's a pretty small amount for HCUP data, at least. I want to say, it's been a while since I bought it, but like $500 or something like that. So most people can come up with that, and then you have an eager person who wants to do it. Because it's easy data to start with, too, to get your feet wet on this kind of work. Yeah.
Laura, I love the fact that you brought up Chapter 55 in Massachusetts, and that was a legislation that actually forced these agencies to share data and link them and lower the barriers for researchers. And I'm wondering what you guys think about how we can advocate at like the legislative level to lower barriers, to get access to these types of data, to lower the cost, to force agencies and health systems to link their data. Should we be working with our health systems or with SAEM or our other advocacy organizations related to emergency medicine to get states or maybe the federal government to require this to happen?
It's a good idea.
Yeah, I think it's a great idea. I think it's all about, how devastating the opioid epidemic has been. It was so compelling, and everybody in Massachusetts was infected in some way by this. So it was really compelling from a human interest and policy standpoint. So it wasn't that hard, and our governor made the opioid epidemic a key priority. So finding the ways, we know why it's important, but finding ways to advocate and to make that story really obvious to the layperson of why they should support it, I think is important. There was a lot done around privacy there too, and I actually was fortunate to work with a Dataset, but it was worth it, but it was definitely an investment. You had to either go to the state DPH to do the analyses or write the code on a dummy data set, send it to them, and they would send it back to you. So making sure that there's robust privacy safeguards is a key for that. but at least we have an example of how it can be done.
I say we have an opportunity with all of the COVID-19 research that's been done.
Yeah.
And a lot of that has been led by, a lot of emergency, medicines.
I think linking it to a public health crisis is key to make it happen. Yeah, so.
Cool. We should talk more.
Yeah.
All right, thank you.
Thank you.